Now coming to the pathophysiology of hip joint osteoarthritis. As you know, that there are certain mechanisms of which actually the nature is protected the hip joint from failing. There are different coverage, there are different issues which actually help to form a smooth kind of articulation between the acetabular socket and femoral head. There is synovial fluid, there is synovial membrane. On the top of it you have a capsule, and all the lubrication is there, and then there is also cartilage, especially the hyaline cartilage. Now what happens is, if all these mechanisms, despite being present, eventually deteriorate over the period of time, leading to osteoarthritis. The problem is that pathophysiology could be primary osteoarthritis, in which actually the disease progresses over the period of time, let's say 20, 30, 40 years of age, and there is actually gradual deterioration of the cartilage over time, which can lead to osteoarthritis. This is specifically called as primary hip osteoarthritis. And then there is another term called as secondary hip osteoarthritis, in which there is actually another precipitating factor which is causing the accelerated degeneration of cartilage, leading to primary hip osteoarthritis. For example, if a patient has some form of, let's for example, dysplasia which was present at the birth, this was probably corrected in form of a pelvic harness, or open reduction or closed reduction was done. Whatever the procedure was done, despite that, there was always some form of a dysplasia which was present at the acetabular level, and gradually the mechanics would be deformed over a period of time. And these patients who have become adult with dysplastic hips, they usually tend to develop osteoarthritis at a very early age. For example, if an osteoarthritis, which in our case, in our patient was at 51 years of age, if the patient would had some form of pathology in form of a dysplastic hip, she may have developed the same problem maybe at, let's say, 30 or 35 years and even 25 years of age as well. So that is something you need to understand, that age is important to help us whether it is most likely a degenerative sequelae of a problem leading to osteoarthritis at the advanced age, let's say at 50s and 60s, or rather some sort of secondary problem which has just been accelerated due to the main secondary cause. For example, if a patient had, let's suppose at 30 years of age, had some form of trauma, patient had an RTA, developed some form of an acetabular fracture, although that was fixed, but there is always a chance in these patients, they over the period of time, in 3 or 4 years of time, they develop some form of osteoarthritis, which can be sometimes debilitating as well. Therefore, this sort of a secondary osteoarthritis due to trauma is usually accelerated. Otherwise, that patient may have developed osteoarthritis, let's say at 50 or 60 years of age. Now, patient may develop within 3 to 4 years or 5 years of the trauma. This is called as secondary osteoarthritis. And usually, there's always some form of precipitating cause, which could be either mechanical or non-mechanical. Non-mechanical causes would include something which is problem with, for example, coagulopathies with the blood can also lead to this sort of a problem as well. Now, it's not always the osteoarthritis of the hip. It can also occur in the knee or even some other joints such as shoulder as well. Usually, but the mechanics is slightly different as compared to the hip and knee. For example, in hip, the weight bearing axis, the axial loading is actually going through mainly towards the superior lateral portion of the hip joint. Therefore, if there is something cartilage starts eroding over there, it would accelerate and quickly develop osteoarthritis. But in the knee, usually the mechanical axis is just medial to the center of the tibia, and therefore this mostly its results increase because due to increased weight of the patients, these patients develop degenerative osteoarthritis of the knee joint. The most commonly involved side is always the medial side. Until unless there is specific reason for development of lateral side, for example, there is associated genovalgum, then patient will develop the lateral compartment osteoarthritis more rapidly as compared to the medially. But most commonly, usually there is slight genovalgum development as the age progresses and the weight bearing axis shifts. Plus, there is increased tendency to develop median compartment osteoarthritis. Now, the patient may develop isolated medial compartment or may also develop medial compartment osteoarthritis, which we eventually spread to patellofemoral as well as the lateral compartment as well. As I told you, exactly the mechanism over here is again almost the similar. You have a knee joint which is actually a complex hinge joint. Now the difference between knee and hip is actually the hip joint is a ball and socket joint which can articulate in 360 degrees, but the knee joint is actually complex hinge joint. There is not only flexion extension occurring at the knee joint, there is slight degree of rotation is possible as well. And as a result, this most commonly, once the medial compartment is involved, the osteoarthritis can spread to the lateral as well as the patellofemoral compartment as well. And once all the three compartments are involved, then probably you require, as the disease progresses, you probably require a full bout of a total knee replacement. Although total knee replacement and total hip replacement is now, it has evolved to a level that it can make a patient completely pain-free, and new generation of prostheses have actually mimic the complex motion at the knee as well as the hip joint. But what's important is that you have to understand that this is not the first step we have to go. When we are dealing with pathophysiology or osteoarthritis with knee or the hip joint, what we need to deal with it is that we need to halt the process and stop the accelerating degeneration of the cartilage before actually going for some form of replacement. There are multiple options which are available, by which we can use halt this process, which is eventually going to increase degeneration and eventually lead to joint destruction. But before that, you need to understand that the process is actually sort of starts at the cartilage level. The problem, once the cracks develops, this leads to some form of erosion. This erosion is most commonly the initial process, or initial start is usually in the medial compartment. Once that is done, then it spreads to other compartments, and that eventually leads to increased cascade of inflammation, pain, and especially the pain on the weight bearing. The problem with the hip joint is that usually when you are not bearing weight, there can be some form of a relief from that pain. But usually during every movement, there's always a pain in the hip joint. With the knee, the main problem is actually not the movement, but is actually when you're bearing weight, it is actually more painful. And patients generally come and complain that initially the problem started at the hip joint. Now the same thing is happening with the knee as well, and they're having a knee osteoarthritis as well as the hip as well. And you can very well imagine how debilitating this can be for the patient who is having associated hip and knee osteoarthritis.